screening guidelines, even if you have a different piece of information in front of you that says otherwise, or if your healthcare provider says, well, I'd really like to have you start your pelvic exams at a certain age. These are the screening guidelines for now. Pelvic exams at age 21, breast exams within the clinical setting at age 19. So a typical question could be, here's your patient's profile, this is the age that she is, this is her background, this is her history, so what kind of screening are you going to recommend to her as her nurse? These are the guidelines for pap smears. And after the age of 65 or older, no pap smears necessarily if they've had a negative history. So again, given your patient's chart, look through there, see if there's anything that warrants you to make a different decision on what kind of screening she should have. And I won't make it confusing. I won't have her be 29 and a half. It'll be clear what age group she falls into. Patient teaching for pap smears. We don't want anything that's going to change the environment. So we don't want you to have any kind of product use, anything like that that's going to change the accuracy of the specimen that we obtain when we do a pap smear. Again, as I said, you can tell that to them, you can send them a printout sheet. I'm going to email you instructions so they don't arrive and think, oh, I can't remember what she said or what he said, and now I came and then I've done something that's going to happen. I need to reschedule my test. So I know this is a lot of information, but I'll just print up a little Word document, I'll give it to you, or I'll email it to you and make sure that you can look that over. And if you have any questions, I put my contact information on that. The HPV test is different than the pap smear. It identifies abnormal cells. True or false? Pap smears can prevent you from getting cervical cancer.
No.
False. Well, then why do I have to have it done? You said it's not going to prevent anything. Correct. Good education on your part. And when you're the healthcare provider and you're working in a doctor's office and you said, hey, you look like you're the age now where you should probably be getting your pap smears done, why don't you get that scheduled sometime? What's the likelihood that patient's going to turn around and go home and get that scheduled? Maybe, maybe not. So who's your healthcare provider? Here's, I have that information pulled up. Or maybe, you know, if you want to, there's a phone here that you can use, and you can call them today and we'll get your appointment set up. Much more likely to occur versus me going home thinking, that is probably a good idea. Maybe one of these days I'll give them a call. I kind of dread doing that. Maybe I won't do it this month or next month. I don't know. It's kind of awful making that appointment if I can't get out of school, and pretty soon time goes by and then the patients do not get that done. Questions about that? You don't need to know the orange table, but just for your own sake of making your patients aware, if we do have an abnormal result, there are different follow-up that we may do. Just because you have an abnormal result doesn't mean you've got cancer. Right? It could be some atypical looking cells that may just warrant a little bit closer follow-up. If we are concerned about what we find, we may have you come in for a biopsy, things like that. So for the patient that's waiting on those results, it's very nerve-wracking when we say, oh, we found something abnormal. And right away my brain goes, oh my God, I got cancer. Again, 65 and older, still want that female to come in for their pelvic exams, their clinical breast exams, and no pap smears if there's no history that warrants that. What age do we begin mammogram screenings? 40. Why don't they do that before that? Why not? Like, why wouldn't I just do it for a 35-year-old or a 30-year-old? Pardon me?
There's not as much of a risk.
Okay.
The
first
radiation,
issue.
isn't that,
If they do have.
are they done by X-ray?
Yes, they would start it earlier, or they might do an MRI. What were you saying?
The breast tissue,
Dense?
You're on the right track.
The radiation?
Breast tissue is too dense, that a mammogram is not helpful. So a mammogram is not helpful for females under the age of 40. Because the breast tissue is too dense, and so the mammogram will not help. Therefore, if a young female under the age of 40 has breast cancer, usually it's pretty far along. Because they have not had that luxury of every year having that mammogram done. So sometimes that's the problem, is no, we don't do mammograms under the age of 40, but when you come in as a 35-year-old and we do a clinical breast exam when we notice a lump, we've not had mammograms to follow up on, and perhaps that patient has had cancer for a period of time and we have not detected it. Mammograms don't replace, for the screenings that we talk about, one doesn't replace the other. A mammogram doesn't replace you doing your monthly breast self-exams. A mammogram does not replace you coming in for a clinical breast exam. So pay attention to the words within the questions on the test. You have a female, when should she come in for a mammogram? When should she do her breast self-exams? When should she do her clinical breast exams? Those are all three different tests. Again, not helpful for men under age of 40. Your patient teaching is, I don't want you doing anything that's going to change the tissue. So no, don't put any deodorant on, no lotion under your armpit or breast chest area, things like that. Mammograms don't take very long, typically. And honestly, I would not recommend having a mammogram done. If you have a female that experiences breast enlargement, extra fluid in your breast at the time of pre-menstruation, I would not have your mammogram done at that point in time. Because they may pick up on that and they may not know if it's a lump or a cyst or extra fluid in the breast. So I usually tell patients, try to schedule your mammograms after your menstrual period so we don't have that hormonal influx that may change the picture. Benign cysts are usually round, marble, smooth, mobile, as opposed to cancerous looking tumors. Which are usually star-shaped and fixed. It's a cancerous finding versus something benign. Again, telling your patient, well, we have found a benign tumor. What does she associate with the word tumor?
Cancer.
Cancer. I would not use that word tumor if it was a benign finding. Because right away, that's where the brain goes. You don't need to know this, but there have been some recommendations on how to have conversation, how to get histories on patients that are sexually related, that are maybe personal, confidential, and this is one model, and you can study it more if you feel like you'd like to. You won't be quizzed on it. Within your book, there was a little bit of discussion about female genital mutilation. You won't have to know that, but just be aware of, you hear that in the news, if you hear that in topics of conversation, that you know what that means. That's countries, people that mutilate female body parts for no specific reason. The term now is called intimate partner violence versus spousal abuse or wife abuse or husband abuse. That's the terminology that we're using right now. It's IPV. And there's some research that goes on as to the disparity of the differences between healthcare for people with disabilities and others. That there's some limitations there. There's a definite lack of access in certain areas and certain parts of our country and our world for that. So CDC put out a resource tool that addresses some of that, how some of that can be managed for disability. terminology, I shouldn't say new, sometimes it seems to change. LGBTQ, if you see that terminology, you're not sure what it means. Right now, this is the definitions. As I said, those have a tendency to change over time. And again, are they getting the same kind of fair treatment, equal access as the rest of people that aren't within that population? Okay, again, as I said, during a pap smear, we obtain samples themselves, put it on a glass slide, send it to the lab for evaluation to determine if there's any atypical cells. Atypical doesn't mean cancer. Atypical doesn't mean cancer. If it's a cancerous lesion, we will probably do a colposcopy. Oscopy means what? Putting a scope in to do an evaluation. It doesn't mean removal of things besides tissue, I guess. And again, if we have concerns about the cells possibly being cancerous, we will probably schedule that patient for a biopsy. Being understanding with the patient, how nerve-wracking that is while you wait for your biopsy to get scheduled. Sitting down, making eye contact with your patient, one-on-one. I know this is scary. And I know that right away we have concerns about this possibly being cancer. We don't know what we're dealing with right now. And being understanding of that person. But like I said, you do that maybe every day in what you're doing. Discharge teaching following that biopsy is you should probably wear a peri pad for a few days because sometimes we have a little bit of mild bleeding that occurs after this biopsy. Nothing's going to increase your risk of bleeding. That's the anticoagulants, that's the aspirin, that's the NSAIDs, that's the G-herbs that we already talked about a few weeks ago. And no douching, no sexual intercourse for a week. We want that site to heal after your biopsy. We don't want to do anything that's going to traumatize that site. That's pretty common sense, but it always, of course, you as a nurse make sure your patient understands that. So what would be your priority question when you do the follow-up for this patient? You call her tomorrow, she had her biopsy today. What's your priority question? You only get to ask her one question, it's a priority question. You're the home care nurse, and you're calling up to follow up following her biopsy. Yes. How many peri pads have you gone through? That's your priority question, right? A, B, C's. Airway, breathing, circulation. So we're kind of, that's your priority question, and that's what the question is, priority. And then we can address all the rest of the concerns and issues that she has. Some of you didn't do so well on your priority questions on the last test. Priority questions should be easy from here on out. Dark tardy stools was the one priority question in last test. Giving that patient oxygen. And some of you all chose, we're going to assess their lungs or whatever the answer was. Assessing is not going to save his life. Performing some action is going to save his life. Assessing her bleeding is going to be addressing her circulation, her bleeding. ABCs is a priority question. How do we manage abnormal tissue? Sometimes we can freeze it to keep it from growing. The word dysplasia there, dys means, DYS means what? Difficult, problematic, exactly. Plasia means abnormal growth. So it either grows somewhere where it's not supposed to grow, or it's doing something it's not supposed to do. So the word dysplasia always means abnormal cell, either function or growth, or going somewhere where it's not supposed to be going, growing. And so that's what that word means. Abnormal tissue, sometimes we can freeze it as a treatment. Again, your concern in red and bold when you're following up with your patient or you're teaching her after she goes home after her cryotherapy is you must contact us if you have excessive bleeding, pain, or a fever. What number is sort of the definition of a fever?
100.
101. shouldn't have to write that down today because that should be pretty common sense.
The book has something.
You may be a little bit crampy, you may have a little bit of watery discharge, but it should not be in like severe excruciating pain. Cone biopsy and what we call a leaf procedure is another procedure. It's spelled out on your screen. It's when we excise abnormal cells or tissue. Again, follow-up is don't do anything that's going to traumatize that site. Including douching, including tampon use, including sexual intercourse. We can again do a biopsy for concerns that we have, abnormal bleeding between menstrual periods, abnormal bleeding following menopause. We'll talk more about that in a bit. Again, there's that word dysplasia. Hyper is an overgrowth of abnormal cells. If I need you to know risk factors, I'll tell you. So I'm not worrying about this one right now, and we'll get to breast cancer risk factors and some other ones here in a bit. Okay, a D&C, we can do that following an incomplete, if the patient has had a miscarriage, if we want to do a D&C to stop irregular bleeding or to diagnose what's going on there. Again, red and bold, reported excessive bleeding, that's pretty common sense. Why, when you do a laparoscopy, does the patient sometimes have shoulder pain? Pardon me? Why do you blow them up with air?
So you can move their organs.
You can see the organs, correct. So we inject CO2 in the pelvic cavity so we can see the organs better. Your patient goes home, doesn't have abdominal pain, but they've got this severe, bizarre shoulder pain. If you don't warn them about that, they're gonna wonder what's going on. This is a weird phenomenon, but this is how we can see your organs when we do this procedure. And just by the way it escapes your belly, sometimes it goes and sets up on your shoulder. It's just weird, but that's just what happens. So do not get alarmed tonight or tomorrow if you have the shoulder pain. It just goes with this procedure. Because it's bizarre when it happens if somebody hasn't warned you that it could happen. Hysteroscopy, hystero means hystero, uterus, correct. Again, scoping into the uterus to evaluate or to obtain tissues, all those kinds of things. Complications. What is an ablation procedure? Ablation. Why would you do that to a patient? That doesn't make any sense. Correct. So again, educating your patient. Oh, we're just gonna go and we're gonna burn some stuff out. Like, oh yeah, great stuff. I don't really want to sign up today. Again, complications relate to bleeding. Here's a big long word. Just break it down. Hystero means we just talked about that. Uterus. Salpingo means no clue.
Fallopian tubes.
Fallopian tubes. And ography means what?
Image.
Ography typically means that we inject contrast. Ography and geography. So we can break that word down. Uterus, fallopian tubes, we're going to inject contrast in to evaluate those parts. Again, you may have a little bit of crampiness following that. You may have to wear peripads for a few hours. You may have a little bit of slight amount of bleeding afterwards. We can do CAT scans. As you know, we can do lots of studies, and they all aren't the same. So the reason we make a decision to do one versus the other is lots of factors. If your patient's going for an MRI, make sure they aren't wearing any patches when they go down for that. Usually you have to have an area that has a checklist of things to check before they go down for their MRI. So just pay attention to that. If you're not sure if it's a contraindication, then contact whoever's doing the MRI to make sure whether that's allowed or not. toxic shock syndrome. Toxic shock syndrome is, as it says, shock. And it came to be more often, I'm sure it existed forever, but when tampons became in use, they weren't always around, right? I mean, it used to be just you had to wear period pads the whole time you're on, or sanitary napkins the whole time you're on your menstrual period. Then tampons came out. Girls thought they were the bomb because they no longer had to wear period pads. And then girls would wear them for 10 hours at a time. And then sometimes girls would wear them 2 at a time because they wanted to go swimming. They didn't want to have to mess around with changing their tampon in the middle of their activity. And then manufacturers started producing super duper heavy duty absorbent ones, right? That you could keep in forever. And then you would find these patients that were getting really sick with toxic shock syndrome because all that stagnant blood that was in that tampon has been in that body cavity for hours and hours and hours and hours. So your teaching for your patient is, I know it's not always convenient, but you really gotta change your tampon at least every 4 hours. And don't wear 2 at a time. And at nighttime, it's probably better actually for you, safer, if you take that tampon out and you just can wear a period pad at night. Versus leaving that tampon in for hours, because it just doesn't make any sense, because that blood just absorbs in there, stays in there, increasing your risk of having toxic shock syndrome. Questions about that? PMS?
She's got a
Most of
question.
you, I probably don't have to tell you about what that involves. Yes?
Do I need to tell a patient that they can get the toxic shock syndrome if they use other forms besides a tampon, such as a cup or some of the other stuff that's
Yeah,
available?
you can.
You can still get that? Okay.
If you don't clean it, some of them they say you have to remove some of those. You're talking about like contraceptive devices and some of those.
Just the period cups.
Seriously.
Because they say that you can wear them for 12 hours.
As a healthcare provider, anytime you're thinking about the fact that there's stagnant blood that's pooling anywhere, you're going to have increased risk of you having toxic shock.
Because it's the blood, not the tampon, that's causing the problem.
The tampon's not the issue. The blood
It's the
staying
blood.
stagnant is the issue.
Okay.
Good question. Because it just builds up bacteria. And it builds up bacteria. It's not you having a tampon in, you leaving the tampon in and all that blood just stays in there for hours.
So like say someone, not that anyone would, but some people do weird things. Say someone was like wearing a tampon and they were not on their period, or like their period was over and they were leaving it in like.
See, that wouldn't really necessarily be an issue.
So it's literally just the blood. If they were putting a tampon in and not on their period, they wouldn't
Correct.
be at risk. Okay.
And like I said, we've had girls that said, why
I thought I
should
read
do it
something
at a
that
time?
says some people do
Things like that. They'll get one out,
when they're not on
another
their
one
period. I
in.
thought that was one of the things that the teacher had to put on their period.
I mean, I always use the cup and on the instructions so they're 12 to 24 hours. What happens to the tampons? They don't.
Correct, for that exactly.
But
Okay, we were, any
instructions
of
on
you
the
guys got
so
your
that you
questions?
get it or you can do it a lot longer. You know,
PMS
like,
detector.
so it's the tampons. I know. She was like, no, that's the blood.
So there is, again, some herbal therapies that people find to be working well. I think it definitely warrants when you have a teenager, a female come in and maybe she's starting her menstrual period, spend a couple minutes and ask her how that's going for her. Because some of these girls are miserable and they don't go to school. They lay in bed for 2 days and they're just miserable every month. That's ridiculous. There's things we can do for you. So so you're 14, I assume that you started your menstrual period, you have your every month regularly. Tell me how that's going for you. Well, I get really big and bloated and I can't wear my jeans for 3 days. I'm miserable, I just bawl all the time. I just want to do something drastic. Or it's not bad, honestly. Take some, Midol and I cruise through it. Well, good. It lasts for 6 days. Well, let's figure out what we can do about some of those things. You shouldn't have to be miserable every month. So there are some herbs that work. So you might want to try one of those. If it's severe enough, we can talk about some other medications. Why would we possibly prescribe oral contraceptives for that female?
To make the period slow, regulation.
Regulate your periods. Correct. So don't freak out, mom or dad, when you give your child or recommend oral contraceptives to your 14-year-old. That doesn't necessarily mean she's sexually active. Sometimes we want that to be better regulated. If you tell me that you're miserable when you're laying in bed for 3 days every month because your hormones are going in, you're having a menstrual period, they're going back down, and then 2 weeks later you're starting all over again. So sometimes if we get an oral contraceptive, we can keep it more like this. Not have this big fluctuation every month, every month, every month. So spend a little time talking with that female about telling me how that's going. Because sometimes they just think that's how it's supposed to be, and then you find out they're just miserable. Pardon me? Again, to decrease the bloating. Sometimes the breasts get really sensitive and filled up with fluid. Sometimes they have a lot of bloating for those days, and sometimes diuretics will help get some of that fluid off. Because there are some females that said, I can't wear the same size clothing when I'm on my menstrual period.
You only use the diuretics for when you're on treatment?
Yes. No, because we don't want a patient having issues with dehydration and stuff like that.
Are those medications would be like lifestyle thing or?
No, we can see how it works for you. You know, say you're getting bloated every month, we can, you know, maybe prescribe a diuretic. You can take that when you're having that issue, and if it works for you, then yeah, you can do that for the next, every time you have your menstrual period, if it's not dehydrating you.
Why did you say we would take calcium?
And you would also
Also
increase
calcium
your
gonna help.
Yes, absolutely. Stay hydrated always, yep. I know that doesn't seem to make sense to you as a patient, because we say you stay hydrated, drink fluids, and then already retaining fluid, but it all works as it should.
Oh, it is.
Because also staying hydrated will help with your headaches and other stuff that is with that. PMDD is a more severe form, to the point where they are at high risk or a risk for suicide, because they just cannot keep their emotions under control due to that hormone level. Monitor for that. We always want to make sure that we're assessing for that, we're staying on top of that. Talk to a parent if you need to. I know that, you know, Lily started her menstruation 6 months ago according to our records. How is that going? Are you noticing anything different at home? How's the behavior? Is there anything that's significant enough that you have concerns about that? This means difficult, problematic. So this is menstruation where there's significant symptoms, more than expected. A means absence of. So the criteria for this diagnosis is either you're 15 and you don't have any secondary sexual characteristics, or you're 16, you have the breast development, you have the rest of it, but you haven't started your menstruation yet. Lots of things, as you can see with the chart, could cause a female to not start her menstrual periods by the time she's supposed to, or not develop characteristics by the time she should. So your job is to do some history taking, see if we can figure out why you haven't started your period even though you're 16. That's primary. Secondary is they started their menstrual periods and then they quit having their menstrual periods. So started on the same age they're supposed to, they have sex characteristics like the female, but then they have stopped menstrual periods. Oftentimes, that too little body fat is a culprit. Because sometimes we have teenagers, they get into high school years, I feel fat, I don't feel like I fit in, I'm just gonna start some crazy diet, I'm gonna run 20 miles a day, and I'm just gonna be physically fit, or they're anorexic or have an eating disorder, and pretty soon, they've stopped their menstrual periods. And then sometimes they don't mind it, right, because they don't have to mess with that every month. But you're gonna mess with your ability to conceive a child down the road if you don't have your menstrual periods as they're supposed to be. That's just the way the body is designed. So, go ahead.
So is there a problem for those in sports and
Sometimes. You're right. Sometimes the ones that are really in sports, that are really physically fit, we find out they don't have menstrual periods because they've stopped because of their increased activity. Which sometimes is not bad, but we have to have the female realize that if you don't have regular cycles now, there's an increased risk of you not having regular cycles when you actually want to have children down the road. So, first of all, identifying that that's what's going on. Are you having your menstrual periods every month? Well, no, I haven't had one for, I don't know, since Christmas. Okay, let's figure out what changed that. There's something that you did differently at Christmas time that has caused you not have menstrual periods since then. And trying, like you can, as you can see, sometimes it's a pituitary disorder, sometimes there's some other body orders system that's causing that patient to have a stoppage of menstrual periods. And as you can see, lots and lots of things can cause a patient to have those. Abnormal uterine bleeding, by definition, is bleeding that occurs either before they're supposed to start their menstrual periods or after they've maybe gone through menopause. So they have uterine bleeding at a time when they're not really supposed to be having it. In red, and bold, and a flag. Tell me how many tampons you're using every time you're having your menstrual period. How long are your menstrual periods lasting? Red flag if they have some indication of dysfunction. Either that my menstrual periods last for 10 days, or I have to change my tampon every hour. Probably more diagnostics are needed. Not probably, definitely more diagnostics are needed to see if there's any indications of cancer or a tumor of some sort. But your menstrual period should not last 10 days. You shouldn't be having a menstrual period for 2 weeks. You shouldn't be changing your tampon every hour. Dyspareunia is difficult or painful sexual intercourse. Lots of things can cause that to be a problem. Perimenopause is considered to be the time around the last menstrual period. So the patient is 52 and says, well, I don't really have menstrual periods every month, like I did. Every couple months, sometimes they are 2 weeks apart, and I go 6 months without having them. Yeah, it sounds like you're probably approaching the perimenopausal ages, where eventually you'll go through menopause. Same perimenopausal symptoms is what we saw and talked about with the PMS. But as you can see the statistics, we definitely might still do our mammograms, we want to do our clinical breast exams, we want to do our self exams, because 16% of breast cancers are within this population. I love teaching college courses because I can do this stuff. Okay, menopause is when the age of menopause is calculated when you've had 12 consecutive months with no menstrual period. So the female comes in, she's 53, and said, I've had a whole year now, I've not had menstrual period. Changes in the body occur, increase in body fat, the hot flashes, that's because the thermoregulation's messed up. Mood changes, lots of things that occur that make menopause pretty miserable for a lot of people. Some meds can cause a patient to have menopausal symptoms, and we'll talk about some of those that take away the hormone feed. We'll talk about some of these today. So the patient's going through menopause, she's miserable, you're trying to figure out how we can manage the symptoms. We used to say, we'll just put you on hormone therapy, we'll put you on low dose, so we'll keep your kind of hormones, because menopause is a result of no more hormone feed that you all have been used to for every month. That's what causes that patient to have all those symptoms. So we used to put people on low dose hormone therapy from now for forever, and make your hot flashes go away. But what goes with hormone therapy is an increased risk of DVTs and blood clots. What goes with hormone therapy risks is that you have an increased risk of blood clots and DVTs. So no, we don't, that's no longer the magical ticket for you, is that I can just put you on hormone therapy from now to the rest of your life, so you don't ever have a hot flash again. We can try it low dose for a short period of time, lowest dose possible, shortest period of time possible to get these symptoms under control, but we don't want to have it for a long time because of your increased risk. That's the explanation for your patient. That's the rationale why we don't do that any longer. And of course, if you already have a risk for other blood clots, we would not put you on any hormone therapy. We'll figure out something else that's going to help with your symptoms. Again, there's lots of alternative therapies. There's lots of complementary therapies. There's herbs that you all can suggest. Herbs don't replace medications. Before you start taking these herbs, make sure you check with your healthcare provider that they don't contraindicate with something else that you're taking. That's your response as the nurse. Herbs are helpful for some people with these symptoms, yes. But let's look through your medication profile list to be sure nothing is interacting with herbs that you plan to take. Bone health is a concern for these females. They have bone loss that's associated with menopause, which can lead to osteoporosis, fragile bones. The recommendation typically is take enough calcium, take enough vitamin D, exercise. Sometimes we'll prescribe bone density tests for the females to see how their bone strength is. Questions about what we just went over. If you were going to pick out probably some of the most important things that you would need to know, tell me some of those. Hormonal therapy, what do you want to know about that?
Risk for DVT and blood clots,
Absolutely,
but they have risk for blood clots from hormone therapy.
correct. What else? The bleeding with all those procedures, yes. Yes, that just makes sense. If you're doing a procedure like that, we want to not traumatize the tissue. We want to make sure that we are keeping track of and assessing any increased bleeding that we have concerns about. Your priority is everything to do. Yep, yeah, for sure. What else? Pardon me? Correct. One doesn't replace the other. The other. Absolutely. How often are you supposed to do your breast self-exams? Monthly, correct. And mammograms don't replace that, just replace that. And why can't I have a mammogram at age 35? They're too dense, it's not helpful. Correct. So therefore, what kind of tumor, cyst on a mammogram would let you know as the nurse, it's probably benign versus cancerous. How does a benign one appear? as opposed to a cancerous one.
Movable and
The
round
nine is typically
symmetry.
round, marble, smooth shaped, and mobile. Like you can put your fingers on it, you can probably move it some. How does a cancerous one appear?
Asymmetric.
It's star shaped and typically fixed, correct. So if you're eyeballing that mammogram, you're like, oh, my first thought is, this one looks like it's cancerous, this one does not. By those, the screenings for sure. So I will give you a female of a certain age, and you're gonna recommend what screenings based on what I give you. Safe tampon use, I would say 4 hours would be the max. I think 8 hours is too long. Causes or definitions of secondary amenorrhea. By the age of 15, if you don't have secondary sex characteristics, right? Or by the age of 16, if you have secondary sex characteristics but did not start your